Hey everyone, Dr. G here, and today we're going to be doing a high yield review of the hematology module. And I want to welcome you to this session. We've done several in the past, and they've really been a hit. So we're going to do today the hematology module. I think this is one of the most tested systems in the PANCE and the PANRE exam, so definitely high yield. If you've been following along, we've been doing several Rosh review guides, kind of a step-by-step look, breaking down each condition and, high yield takeaways that will help you succeed on any test that you take. And this review is really going to cover it all. We're going to do clotting disorders, cytopenias, malignancies, kind of the whole PANCE blueprint. And along the way, we'll drop in some of what I like to call pro-PA tips. So whether you're preparing for your end of rotation exams, your PACRAT, your end of curriculum exam, or your PANCE or PANRE, this is the high yield review for you. So let's dive in. All right, first off, the first thing on the Rosh review is this quick hit of the coagulation cascade, showing the intrinsic and extrinsic pathways as well as the final common pathway. I think it's kind of hard to test this from a pathophys or a phys perspective, but I think if you don't understand the pathways, it makes it really hard to understand where the problems lie when we talk about certain coagulation disorders. So I think it's definitely worth revisiting. I'm not going to go through it in depth here. I just don't have the time. But we are going to jump right into hemophilia A. So hemophilia A is a congenital deficiency, and it's of factor 8. Okay. And this is part of the intrinsic pathway. So when we look up here, it's part of this pathway. And it is because this factor is missing, basically, patients can't form stable fibrin clots and they experience prolonged bleeding even after minor injuries. So we often see it in children. It is an X-linked recessive disorder, which means we most often see it in males. And sometimes females can be carriers, but we often see it in males and in children. Clinically, these patients present with recurrent bleeding into the joints. It's called hemarthrosis, and they have deep tissue bleeding after trauma or surgery. And you might also have some easy bruising or prolonged bleeding after dental work. Those are things to look for in vignettes in clinical practice. On labs, you'll notice a prolonged PTT, but the PT and the platelet count remain normal. This is because the problem is isolated to the intrinsic pathway. The diagnosis is really confirmed by finding low factor 8 levels on assay, and the treatment really depends on severity. So for acute bleeding or prophylaxis, we give the factor 8 concentrate. And for mild disease, we can give some desmopressin or DDAVP, and this can help because it releases the stored factor 8 and von Willebrand factor from the endothelial cells. So moving on to hemophilia B, or Christmas disease. This is a factor 9 deficiency. So hemophilia B is very similar to hemophilia A, but instead of lacking factor 8, the problem here is in factor 9. So like hemophilia A, it's X-linked recessive, so most often affecting males, causes impaired clot formation through the intrinsic pathway as well. And clinically, it looks almost identical to hemophilia A. Patients have that recurrent joint bleeding, easy bruising, prolonged bleeding after surgery or trauma. And on labs, you'll see, again, a prolonged PTT, but normal PT and platelets. And the diagnosis is really confirmed using that factor 9 assay, which shows low activity. Treatment for hemophilia B really involves a factor 9 concentrate replacement, and it's given for both acute bleeds and for prophylaxis. And unlike hemophilia A, desmopressin doesn't really work here because it doesn't increase those factor 9 levels. So here, a quick at a glance, hemophilia A, 8 is the factor. Hemophilia B is going to be factor 9. And appropriate tip, if a patient looks like they have hemophilia A but doesn't respond to DDAVP, you're going to think hemophilia B. All right. Moving on down. So this is factor 11. This is von Willebrand disease. So von Willebrand disease is most common inherited bleeding disorder that we have. It involves a problem with the von Willebrand factor, which is the protein that helps platelets stick to damaged blood vessel walls, and it also carries factor 8. So when von Willebrand factor is low or dysfunctional, both platelet adhesion and factor 8 levels are affected. So that's what it's saying here. When von Willebrand factor is low or dysfunctional, both the platelet adhesion and factor VIII levels are affected. That means that patients can have signs of both platelet type bleeding and mild coagulation problems. Patients typically present with mucocutaneous bleeding, things like frequent nosebleeds, gum bleeding, easy bruising, heavy menstrual periods. And the bleeding often happens immediately after injury or surgery, which helps distinguish it from delayed bleeding we see in hemophilia. On lab work, let's look at the labs. So you'll usually see a prolonged bleeding time because the platelets can't stick properly. And sometimes you'll have a mildly prolonged PTT since the factor VIII levels can also be low, but the PT and the platelet count are normal. Treatment depends on severity. For mild disease, we'll use DDAVP. And in more severe cases, when DDAVP is not enough, we'll give the von Willebrand factor containing factor concentrates. And of course, patients should avoid aspirin and NSAIDs and those things which can worsen the bleeding time. So a pro PA tip, if you see mucosal bleeding with normal platelet count but a prolonged PTT, think von Willebrand disease. And remember, DDAVP works well here and in hemophilia A, but not in hemophilia B. All right. So there is also a hemophilia C, although Rosh didn't think it was important enough to include on this quick hit review, so I'm not going to talk about it here, but just know that it does exist. So next up, let's talk about immune thrombocytopenic purpura. So ITP is an autoimmune disorder where the body produces antibodies that attack platelets. So they attack the platelets and basically mark them for destruction. The spleen marks them for destruction. And the result is an isolated thrombocytopenia, meaning that the platelet count is low, but everything else in the blood looks pretty normal. And ITP can occur, after a viral infection, especially in kiddos, or it can be chronic in adults. Sometimes it's associated with other autoimmune conditions like lupus or HIV. But patients usually present with signs of mucocutaneous bleeding, so easy skin or easy bleeding, things like petechia, purpura, nosebleeds, gum bleeding, easy bruising. And despite all this bleeding, they're really not that sick appearing. There's no fever, no splenomegaly, and really no systemic illness. On labs, you're really looking for that isolated low platelet count. We're looking at platelets less than 50,000. But really anything less than 100,000, we want to be a little leery about. The PT, PTT, red cell indices, those are all going to be normal. And the problem is really the platelet destruction, not coagulation or production. As in children, ITP is often self-limited and it kind of resolves on its own after a viral illness, so observation is appropriate in mild cases. But for adults, patients with more severe bleeding, or we usually treat with steroids, corticosteroids as first-line therapy. And if the patient doesn't respond, we can consider giving IVIG. Okay. So basically, when you see an isolated thrombocytopenia with a normal PT, PTT, think ITP, especially if the patient looks pretty well. All right. Moving on, we have TTP, or thrombotic thrombocytopenic purpura. And in this is a life-threatening emergency, and this is caused by a deficiency of the enzymes of the ADAMS13. So this enzyme's job is really to break down large von Willebrand factor multimers. And when it's missing or it's blocked, these multimers accumulate and they cause widespread platelet aggregation and microthrombi formation throughout the body. And as we can imagine, all of these microthrombi clog the small vessels, and they can also shear apart the red blood cells, leading to hemolysis, organ damage, and consumption of the platelets. So there's a classic pentad to remember for TTP. And I don't know if you've ever heard of the classic pentad, but it's essentially fat RN. And the F is going to stand for fever, the A for anemia, okay, and it's usually a microangiopathic hemolytic anemia. T is thrombocytopenia, R, renal failure, and N is going to be neurologic abnormalities like confusion, headache, or seizures. As far as, let's go back over here. So as far as lab work, We're going to see the low platelets, signs of hemolysis. We're also going to have an elevated LDH and indirect bilirubin, low haptoglobin, and schistocytes on the peripheral smear. And the PT and PTT are usually normal, which helps us distinguish it from things like DIC. Treatment, we have to start it as quickly as possible. Mainstay is going to be urgent plasma exchange or plasmapheresis to remove those antibodies and replace the Adams 13. Corticosteroids are also given to reduce immune activity, and we want to remember never to give the platelets in TTP because it can make the thrombosis worse. All right, let's move on down to HIT. So heparin-induced thrombocytopenia, or HIT, is a really serious immune-mediated reaction. It can occur after recently starting heparin. And so instead of causing bleeding like other thrombocytopenias that we've seen, HIT actually causes clotting, and it makes it pretty dangerous when it comes to drug reactions in medicine. So here's what happens. Heparin binds to a protein called platelet factor 4, and it forms a complex. In some patients, the immune system makes IgG antibodies against that complex, and when those antibodies bind, they activate platelets, leading to widespread clot formation and platelet consumption. So platelets go down, but thrombosis goes up. And HIT usually develops about 5 to 10-ish days after starting heparin, but it can appear sooner in someone who's been exposed to heparin before. And so patients usually present with this sudden drop in the platelet count, so usually about 50% decrease or more, and they develop new clots like DVTs and PEs and other things. Bleeding is really uncommon. To diagnose it, you're going to see the thrombocytopenia in the setting of recent heparin use, and we might also have confirmation from a positive PF4 heparin antibody test or a serotonin release assay. Most important step in management is really to stop heparin, and then you'll start a non-heparin anticoagulant. So if your patient, is on heparin and they start to develop low platelets and new thrombosis, you're going to think of HIT. All right, let's keep going. Let's move on to DIC. So DIC is a pathologic process where the body basically both clots and bleeds at the same time. And it's not a primary disease. It's a secondary complication that occurs in response to like a major trigger like sepsis, trauma, malignancy, or obstetric emergencies. Like placental abruption or amniotic fluid embolism. So here's what happens. You have a massive inflammatory or tissue injury that activates the coagulation cascade throughout the body, and that really leads to a widespread microthrombi formation, which consumes all the platelets and all the clotting factors. And then as those factors get kind of used up, the body can no longer maintain the hemostasis, and so this results in diffuse bleeding. And clinically, patients can present very, very ill. They're usually oozing from their IV sites. They start bleeding from their mucous membranes or nose, and they get petechiae or purpura. And organ dysfunction can usually occur because of all the microthrombi that they throw, such as things like renal failure, hepatic injury, respiratory distress. And basically on lab work, you're going to see the platelet count being low. The PT and PTT are both prolonged, and the fibrinogen is also going to be decreased. D-dimer, you can get a D-dimer. It's usually elevated, and a peripheral smear might show some schistocytes from the red cell fragmentation. So treatment, you want to treat the underlying condition because remember, this is not a primary condition. This is following something else. Other things we can do is supportive care. If bleeding complications are present, we want to replete the clotting factors and platelets with FFP and platelets. Okay. Moving on to this little chart here, we have a nice little kind of wrap-up chart of the different disorders of coagulation. We've already talked about hemophilia A, B, von Willebrand, DIC. We have not talked about polycythemia vera, protein CNS deficiency, and factor V Leiden. I would just go through here and be very, vaguely familiar with them to differentiate the two or three of these from one another. All right, moving on. So moving on to the hematopoiesis, this is more pathophys or phys. I would definitely understand the different cell lines and where they come from. But more importantly, I think we need to know the different causes of anemia. So you definitely want to know your microcytic versus your normocytic versus your macrocytic, and which different types of anemia fall into those different categories. That you should be at baseline familiar with, and then you can start going in more depth to the different causes. So the first one we're going to talk about is iron deficiency anemia. So this is definitely the most common cause of anemia worldwide. It results from basically decreased iron stores in the body, which leads to reduced hemoglobin production, smaller and paler red blood cells. So you can see those down here. They're hypochromic and microcytic. The most common cause of this is really chronic blood loss, especially from the GI tract or heavy menstrual bleeding. And other causes can include things like poor dietary intake, malabsorption, or things like after gastric bypass surgery. And patients usually present with fatigue, pallor, tachycardia, weakness, glossitis, spooned nails, and they can also have a little bit of shortness of breath on exertion. Another thing that we see commonly with this is pica, which is a craving for non-food items like ice or clay. And you might also notice again that glossitis, which is a smooth, shiny looking tongue. Labs. Let's talk about lab work. So on labs, you'll find a pretty classic pattern. You're going to see a low serum iron, a low ferritin, and a high TIBC because you have a lot of sites that are not bound. And you also have a low transferrin saturation. Another thing you'll see on the smear is a microcytic hypochromic red blood cells. Treatment usually involves replacing the missing iron, so giving iron supplements, also taking vitamin C to help it absorb. And if oral therapy isn't tolerated or not feasible, then we can give IV iron. And we also want to address why the patient is getting anemic or iron deficient by maybe placing patients on oral contraceptive pills to help regulate their menses, and also like GI consults if we're worried about GI blood loss. All right. Well, I guess real quick, a pro PA tip. When you see low ferritin and high TIBC, you want to think iron deficiency anemia. So next up we have sideroblastic anemia. This is also a microcytic anemia, but it's not caused by a lack of iron, but inability to properly incorporate iron into the hemoglobin. And this is really during red blood cell production. So in other words, the body just has plenty of iron, but it can't use it correctly. And so the iron really builds up inside the red cells and in the bone marrow. And this condition can be congenital, but it's more commonly acquired. And the acquired form comes from usually like chronic alcohol use, lead poisoning, B6 deficiency, and it can also happen when patients are taking isoniazid for TB without the B6, and in myelodysplastic syndromes in older adults. So patients often present with the typical symptoms of anemia, fatigue, weakness, pallor, but there are some clues in the history like heavy alcohol use, medication known to interfere with B6 metabolism. So on lab work, the iron studies are pretty different from iron deficiency anemia. You'll see an elevated serum iron and high ferritin levels, but you'll see a low TIBC. This is because the body has plenty of iron, actually has an overload, but it's not able to use it. So you look at bone marrow samples, and you'll see that the bone marrow sample stained with the Prussian blue. You'll see the ringed sideroblasts, and these are basically red cell precursors with iron granules encircling the nucleus. So there's little iron around there, and this is really a defining feature of the sideroblastic anemia. Treatment, we're really going to focus on the underlying cause. So if they're alcohol drinkers, we want to stop the alcohol or any of the offending agents like medications. This will kind of help the red cell production, especially in cases caused by like isoniazid. Appropriate tip, if you see microcytic anemia with high iron and ring sideroblast, you want to think that's sideroblastic anemia. So next up, we're going to talk really briefly about lead poisoning anemia. So this is caused So lead poisoning anemia is a microcytic anemia because it really interferes with heme synthesis. It's most common in children exposed to lead-based paints in older homes or contaminated water or soil. The presentation can really vary by age, but in kids, we have some developmental delays, learning problems, behavioral changes. In adults, they often get this abdominal pain, constipation, headaches, and neurological symptoms like peripheral neuropathy. And classically, we see it like a wrist drop or a foot drop. On labs and a smear, you'll see some classic clues like basophilic stippling on the peripheral smear, and the serum lead level will be elevated, as well as the free erythrocyte proporphyrin, which will be increased as well. And you might see some of those classic ring sideroblast as well. Treatment is really removing the source of exposure. So if they're in a lead-based paint house, you want to remove them from that or remove the lead-based paint. For kids with really high levels, they can also have chelation therapy. Appropriate tip: if you see a patient with a microcytic anemia, basophilic stippling, abdominal pain, neuropathy, you want to think lead poisoning. All right. And then this is a picture of some of the lead lines on the bones. All right, next up is megaloblastic anemia, which we've probably covered in hematology as well as maybe in our vitamin deficiencies. So megaloblastic anemia really encompasses vitamin B12 and folate deficiency. It's a macrocytic anemia, which means the red blood cells are larger than normal. And it happens when there's a problem with DNA synthesis during red blood cell production. And the two main culprits, like we mentioned, are going to be vitamin B12 deficiency and folate deficiency. And both of these vitamins are really essential for DNA replication. And when they're missing, the cell division slows down and the red cells are released big and immature and fragile. So on peripheral smear, we usually see these macrocytosis and hypersegmented neutrophils on here, which look like this. So I think it's best, let's start out with B12 and then we'll move on to folate. So B12, this is most often caused by what we call pernicious anemia, where the body makes antibodies that destroy intrinsic factor. Other causes can include gastric bypass surgery, ileoresection, vegan diets, alcoholism, tapeworms. And a B12 deficiency presents usually with anemia, fatigue, pallor, weakness, glossitis, but they can also develop neurologic symptoms. And I remember B12, the 12 cranial nerves, that's how I remember that they can have neurologic findings like paresthesias, ataxia, and cognitive changes. So on labs, you'll see that elevated MCV will be greater than 100 usually. You also see those classic hypersegmented neutrophils and low B12 levels. As far as management, we want to supplement the deficient vitamins. And we usually start with intramuscular injections and then move on to the oral. Next, let's talk about, I guess, folate deficiency. I don't see it here. But let's talk about folate deficiency. So I think they're important. As far as folate deficiency, it has pretty similar lab findings as B12. They'll have the same high MCV, hypersegmented neutrophils, but folate deficiency usually results from poor dietary intake, like in alcoholics or people that just eat limited fruit or vegetables. And it also can be caused by pregnancy. So on lab work, you'll see the low serum folate and a normal methylmalonic acid, but an elevated homocysteine. And treatment is really simple. You give oral folic acid supplementation, and it does not typically cause neurological findings. Okay, moving on to anemia of chronic disease. So this is one of the most common anemias you'll see in clinical practice. It's typically normocytic. Sometimes it can be a little bit microcytic, but it's not caused by blood loss or vitamin deficiency. It's really caused by the inflammation of whatever process is going on. And so patients usually present with symptoms of underlying condition, not the anemia itself. The anemia becomes more severe. They might have a little bit of fatigue or vague symptoms, and the lab pattern is going to show that classic normocytic low serum iron, or a little bit high to normal ferritin. All right, we already talked about B12. And then here is just kind of side-by-side iron deficiency anemia versus anemia of chronic disease versus thalassemia. Next up, we have hemolytic anemia. So let me just peek. Okay. So hemolytic anemia refers pretty much to any condition where the red blood cells are being destroyed faster than they can be made. And so the bone marrow responds by ramping up production, which leads to an elevated reticulocyte count. And this is really one of the key lab findings for hemolysis. There are two kind of broad types to remember. There's intrinsic causes, which come from a defect in the red blood cell itself, like hereditary spherocytosis or G6PD. And then there's also extrinsic causes, which come from outside forces like autoimmune hemolysis, infections, or mechanical destruction from like a prosthetic heart valve. Clinically, patients look quite variable, really just depends on how rapidly the cells are being destroyed. But they a lot of times will present with kind of a fatigue, pallor, jaundice, and sometimes some dark urine, and maybe some splenomegaly. Let's see, lab findings. You can kind of see here they'll have the low haptoglobin, increased reticulocyte count is a big one. LDH and indirect bilirubin levels are elevated, and the peripheral smear you might see some schistocytes. Let's see. If the hemolysis is autoimmune, you'll have the direct Coombs test, which will be positive. Treatment is really just dependent on the cause. All right, let's look at transient aplastic crisis. So this is a temporary condition in which those red blood cell production lines suddenly stop. And usually in someone that has some sort of chronic hemolytic disorder like sickle cell anemia, iron deficiency anemia, hereditary spherocytosis, something like that. And the bone marrow, which is normally compensating for this ongoing hemolysis, it just shuts down and the patient develops severe anemia. And it's really abrupt in nature, kind of like almost overnight. The most common cause of this is actually going to be a parvovirus B19 infection because the virus kind of targets and destroys the bone marrow. And clinically, patients are going to present with anemia, pallor, fatigue, lethargy, shortness of breath, and they often have a history of a recent viral illness. And you'll notice their reticulocyte, it drops suddenly, which is a key clue for this. On labs, you'll see, again, the severe anemia. You might see that low reticulocyte count, and white blood cells and platelets will remain normal. Treatment is really supportive, so most cases resolve on their own within about 1 to 2 weeks. And for patients with significant anemia, we might try blood transfusions. And for the severely immunocompromised patients, we might try the IV immunoglobulin. Right? Hereditary spherocytosis. So this is a genetic red blood cell membrane disorder. It is autosomal dominant. So normally red blood cells, they're shaped like flexible biconcave discs, allowing them to squeeze through the tiny little capillary beds. But in hereditary spherocytosis, there's deficits in the proteins, which make the cell membrane unstable and they lose their shape, turning them into spherocytes. And these kind of get trapped and destroyed in the spleen, which leads to chronic extravascular hemolytic anemia. And in this condition, it's usually inherited, and they commonly experience this anemia, pallor, fatigue, the jaundice, and splenomegaly. As far as lab work, we're going to see the classic hemolytic anemia picture: elevated retic counts, increased LDH, decreased bilirubin, low haptoglobin, and we'll see those classic Hal-Jolly bodies. Okay. Let's see. So as far as management, we want to encourage the daily folic acid supplementation, and the splenectomy is often curative for this if needed. G6PD, or glucose 6-phosphate dehydrogenase. This is an X-linked recessive disorder, and it makes red blood cells more vulnerable to oxidative stress. Because the G6PD enzyme helps protect the red blood cells from oxidative damage, a deficiency really just means that when these cells are exposed to certain stressors, their membranes break down and it causes acute hemolysis. So it primarily affects men, and it's more common in individuals of African, Mediterranean, or Asian descent. Most patients are asymptomatic until they encounter some sort of oxidative trigger, and the common triggers include certain things like drugs, infections, and the classic fava bean. Okay. The medications to remember really are sulfa drugs. They tend to cause it, antimalarials, and nitrofurantoin. So after exposure, patients usually have this sudden onset of fatigue, jaundice, dark urine, and on lab work, we'll see the signs and symptoms or the signs of hemolytic anemia. On peripheral smear, you might see bite cells, and you might also see the Heinz bodies, which are kind of clumps of oxidized hemoglobin here. As far as treatment, it's going to be supportive for the most part. Main priority is really just to remove the offending agent and allow the bone marrow to kind of regenerate. And in most cases, hemolysis itself is also self-limited, but for severe anemia, we can consider blood transfusions. Next up is aplastic anemia. So we'll see in this case, it's basically a bone marrow failure disorder in which the bone marrow kind of stops producing all three major blood cell lines. So that includes red cells, white cells, and platelets. So instead of just anemia, these patients have pancytopenia, meaning the low counts across the board. And this condition can be acquired or congenital, and most cases are acquired. Common causes can be autoimmune destruction, medications, viral infections, and in some cases, exposure to radiation or toxins can also cause it. They often have symptoms related to all three cytopenias, so they might have mucosal hemorrhage, prolonged menstrual bleeding, petechiae, ecchymosis, fatigue, recurrent infections, fever. On lab work, we'll see the pancytopenia and a low reticulocyte count because the bone marrow really just isn't making any new cells. And the peripheral smear usually looks pretty bland. There's not really a lot of abnormal cells, just a lack of cells altogether. And the diagnosis is confirmed with the bone marrow biopsy. We see those hypocellular marrow, just fat instead of hematopoietic cells. Treatment really just depends on the patient's age and severity. Mild cases, we're going to remove the offending agent, supportive care. For more severe disease, we might do a bone marrow transplant, and then other older adults and those without a donor might use immunosuppressive therapy. All right, moving on to some of the cytoses. We mentioned these in the chart towards the beginning, but now we're going to go into a little more depth. So polycythemia vera, this is a bone marrow disorder characterized by excessive production of red blood cells and sometimes white cells and platelets as well. And one of the myeloproliferative neoplasms, meaning that it is caused by a clonal mutation in the marrow that leads to uncontrolled growth, uncontrolled blood cell growth. The key mutation here is that JAK2 gene, and a result, the blood basically becomes really thick and viscous, which increases thromboses, strokes, and MIs. Patients often present with headache, dizziness, and pruritus, especially after a hot shower, and they can also have flushing of the face, splenomegaly from extramedullary hematopoiesis as well. On lab work, the hematocrit and hemoglobin are elevated, and the erythropoietin level is low. And this is because the bone marrow is producing red cells autonomously. The JAK2 mutation confirms the diagnosis. And treatment really just focus on reducing blood viscosity and preventing thrombosis. So you can use phlebotomy and low-dose aspirin as well as hydroxyurea. All right, let's keep going. So next up, let's talk about hemochromatosis. So hemochromatosis is a disorder of iron overload. The body absorbs and stores too much iron over a long period of time, and it can build up in organs, leading to progressive damage, especially in the liver, the pancreas, and the heart. So there's really two main forms of hemochromatosis, the primary or hereditary, and the secondary, which is acquired. Extra iron doesn't leave the body very easily, so it kind of deposits in some of the organs that we see down here. And this leads to characteristic triad known as bronze diabetes. Okay, that refers to things like cirrhosis, diabetes mellitus, and hyperpigmented skin. They can also have fatigue, arthralgias, cardiomyopathy, and lab findings are going to show an elevated serum iron, increased ferritin, and a high transferrin saturation, so usually above 45%. The TIBC is low since the body already has too much iron, and the diagnosis can be made with genetic testing for the HFE mutation or a liver biopsy. Treatment is going to involve removing excessive iron, usually through regular phlebotomy, and then you can also remove via chelation therapy. All right, moving on to sickle cell disease. So sickle cell is an inherited hemoglobinopathy. It's caused by a mutation of the beta globin gene. And basically what happens is hemoglobin S is exposed to low oxygen, dehydration, acidosis, red blood cells. They basically change their shape into a rigid sickle cell shape. And these can lead to chronic hemolytic anemia and vascular occlusion. The disease is typically autosomal recessive, and clinically, patients often present with anemia, jaundice, and sometimes they can have those classic pain crises. They're severe episodes of pain due to the vaso-occlusion. And this often happens like in the bones, in the chest, and the abdomen. Repeat occlusions can lead to organ damage. And so one important complication to remember is acute chest syndrome, which presents with chest pain, fever, and pulmonary infiltrates. Another complications include stroke, priapism, and infections. And on labs, you'll see a normocytic anemia, elevated reticulocyte count, target cells, and sickled cells. And the diagnostic test is going to be the hemoglobin or electrophoresis. As far as management, we can use opioid protocol for the acute pain crises and hydroxyurea to reduce the frequency of those crises. All right, here's some common complications in sickle cell disease. I think you should be vaguely familiar with these and why they occur. All right, moving on. This is probably a good time to take a break if you need one. So go ahead and get up, stretch yourself out, and come back. All right, so next up we have the thalassemias. So alpha thalassemia comes first. This is an inherited disorder. Basically, you have decreased alpha globin chain production, leading to a microcytic anemia. So if you can remember, a normal adult hemoglobin is made of 2 alpha and 2 beta chains. So you can see those down here. And when you lose the alpha chains, you get an imbalance. So too many beta chains are produced, and this makes the chain kind of an unstable, and this can damage the red blood cells. So the alpha globin gene lives on chromosome 16. And so one gene deletion is going to be a silent carrier, no anemia, no symptoms. 2 genes is going to be alpha thalassemia trait, which causes a mild macrocytic anemia, and it can be mistaken for something like iron deficiency. 3 genes inactive, this is called hemoglobin H disease, and this causes microcytic hypochromic anemia and splenomegaly. And then the 4 gene inactive is basically hydrops fetalis, so no fetal, no adult hemoglobin, and this usually causes fetal demise. Okay. Most patients with 2 or 3 gene deletions present with fatigue, pallor, microcytic, hypochromic red cells. And then as far as diagnostic testing, hemoglobin electrophoresis is what we use for this. Treatment really just depends on the severity. So mild cases require no therapy, whereas you might need some folic acid supplementation, avoiding oxidative drugs, and occasional transfusions. And in severe cases, we might perform a splenectomy or a stem cell transplant. Next up, we have beta thalassemia. So this is also an inherited disorder of reduced or absent beta globin chain production, and it also leads to a microcytic anemia. It's similar in concept to the alpha thalassemia, but this one's basically the beta chains instead. These genes are located on chromosome 11, and the severity really just depends if one or both of the genes are affected. So there are three main forms. We have the beta thalassemia minor trait, which is the mildest form. There's the beta thalassemia intermedia, which has two abnormal genes, and they might have moderate anemia but survive without regular transfusions. And then we have the beta thalassemia major Cooley's anemia, which is right here. And those have two non-functional genes, and they're severe transfusion dependent, and they usually occur in early childhood. So here's the three: major, intermediate, and minor. On lab work, you'll see low severe anemia, low hemoglobin, low MCV, and target cells on the smear. Let's see, treatment really just depends on the severity. Minor, you don't really need treatment. Intermediate, you might have occasional transfusions or folic acid supplementation. And major requires lifelong transfusions with chelation therapy. And the really only potential cure is going to be the bone marrow transplant. All right, next up, we're moving on to some of the immunologic disorders, and this one is hemolytic transfusion reaction. This basically occurs when you have incompatible blood and it's transfused, and the recipient's immune system is like, oh, wait, hang on, that's not the right type of blood, and it starts attacking the donor red blood cells. It's really serious, and the complications can be life-threatening. So there's two major types, acute and delayed. The acute one is going to occur within minutes to hours, and the delayed happens days to weeks after the transfusion. As far as the symptoms, we're going to see headache, nausea, vomiting, myalgias, dark urine, hypotension, and the management is really going to be to stop the transfusion. This is especially in the more acute reactions. You're going to monitor urine output and consider diuretics, and then delayed reactions are usually self-limited, so supportive care and avoidance of the offending agent. Appropriate tip: if a patient develops fever, back pain, and dark urine after or during a transfusion, you want to stop the transfusion immediately and think about an acute hemolytic reaction. All right, so some blood transfusion reactions. This is a nice little chart here to compare and contrast the different types. And so timing of the reaction is going to be your biggest clue to these. We have all of them listed here. I'm going to let you go through those independently, but I think it'd be a good thing to look at. Moving on. We are now moving on to some of the neoplasms. So this one is acute lymphoblastic anemia, or ALL, and it is a malignancy of the lymphoid stem cells. Most of these are going to be affecting children, especially between the ages of 2 and 5. And it's actually the most common childhood cancer, but it can occur in adults as well. And when it does, it has a poor prognosis. So it starts usually when immature lymphoid precursors called lymphoblasts proliferate uncontrollably. And this really leads to pancytopenia, fever, fatigue, pallor, easy bruising, recurrent infections. You might also see some bone pain, limping, fever, lymphadenopathy, and possibly some hepatosplenomegaly. The key finding on exams is CNS involvement, which can cause like headaches, fever, headache or vomiting, cranial nerve palsies. And on lab work, you're going to see the elevated WBCs, and they're usually more immature lymphoblasts. And peripheral smear is going to show those large nuclei and scant cytoplasm. Okay, otherwise known as blast cells. Okay. As far as prognosis, so kids usually have a pretty excellent prognosis where the cure rate's above 80. Adults, however, have a worse off prognosis. So, pro PA tip: you see a kiddo with bone pain, hepatosplenomegaly, blasts on the smear, think ALL. Okay. Moving on, we have CLL. So this is a chronic lymphocytic leukemia. This is a slowly progressive malignancy of mature B lymphocytes. So we most commonly see it in adults, especially older men, typically over the age of 60 years old. So unlike leukemias that flood the marrow and blast, CLL involves the small, mature appearing but functionally defective lymphocytes. And these abnormal cells don't fight infection effectively and crowd out healthy white blood cells. So a lot of times these patients can be asymptomatic at diagnosis and they discover it incidentally by ordering a CBC, but others can show marked lymphocytosis and smudge cells on the smear. On lab work, you'll also find a very high lymphocyte count, like usually greater than 100,000, and you'll also see some of those classic smudge cells. There is a staging system for this. It's called the Rye staging. So you should kind of be familiar with the different ones. Low being lymphocytosis only, intermediate is lymphadenopathy and organomegaly, and then stage 3 through 4 is going to be anemia and thrombocytopenia. Treatment really just depends on the symptoms and the stage. So many early stage patients have kind of a watch and wait therapy, whereas chemotherapy can be used in conjunction with some of the other medications. And CLL has a variable course. Some patients do really well and live for decades, while others progress really rapidly and transform into large B-cell lymphomas, or also known as the Richter transformation. All right, moving on, acute myeloid leukemia, or AML. So this is a malignancy of the myeloid cell line. So we're no longer in the lymphoid, we're in the myeloid. And these usually accumulate mature myeloblasts in the bone marrow, in the peripheral blood. And this is the most common acute leukemia in adults, usually around the age of 60. And it can come on its own, or it can evolve from prior myelodysplastic syndrome. And let's see, some of the major symptoms we see are fever, fatigue, and anemia. Can also see some bleeding issues and hepatosplenomegaly. Diagnosis, you'll see elevated WBCs on peripheral smear, myeloblast, Auer rods. You'll see those. And then the bone marrow biopsy is going to confirm the diagnosis with greater than 20% of myeloblasts. Let's see, prognosis. Well, treatment, really, we're going to use induction chemotherapy. And then as far as prognosis, it really just depends on the age and the cytogenic genetics. So younger patients with favorable mutations can respond really well. So it really just depends. As far as CML, so this is myeloproliferative neoplasm. It has uncontrolled production of mature and maturing granulocytes. So unlike AML, CML, the cells are more mature, but they're still abnormal and they're proliferative. So this one's going to have the classic Philadelphia chromosome, which results in a T9 to 22 translocation. Usually we have, in this case, more of a middle-aged adult, and some are asymptomatic, where others result from hypermetabolism and splenomegaly, and they might also have the generalized fatigue, weight loss, night sweats, and fullness in the left upper quadrant. On lab work, we'll see elevated white blood cells, usually over 100,000 with the left shift, meaning that all stages of the myeloid maturation are present, like myelocytes, metamyelocytes, and bands. And you might also have basophilia and eosinophilia. Platelets can also be increased. So there are different phases. There's a chronic phase, the accelerated phase, and the blast crisis. And treatment really is been revolutionized with the tyrosine kinase inhibitors such as imatinib, or Gleevec. So appropriate tip is, if you see marked leukocytosis, splenomegaly, and the Philadelphia chromosome, you want to think CML. Moving on, let's talk about the lymphomas. So first off, we have Burkitt lymphoma. Burkitt is highly aggressive. It's a B-cell non-Hodgkin lymphoma, and it has a really rapid growth rate. In fact, it's like one of the most fastest growing human tumors that there is. It's commonly associated with the translocation of the CMYC oncogene on chromosome 8. We have three main variants. We have the endemic, which is the African type, We have the sporadic non-endemic type and the immunodeficiency associated type. Clinically, Burkitt lymphoma, we often see a rapidly enlarging mass over the jaw. And its rapid growth is going to lead to a tumor lysis syndrome. And on lab work, we're going to see that peripheral smear showing that starry sky pattern. And treatment is going to be urgent multi-agent chemotherapy. Right. And really, despite the aggressiveness, Burkitt lymphoma is pretty chemosensitive. And so the cure rates are actually pretty good when you treat them promptly. Next up is Hodgkin lymphoma. So Hodgkin lymphoma is a malignant disorder of the B lymphocytes, and we always looking for the presence of the Reed-Sternberg cells, or a classic owl's eye appearance. There are two major categories of this. There's the classic Hodgkin lymphoma and the nodular lymphocyte predominant Hodgkin lymphoma. Hodgkin lymphoma has a bimodal age distribution, so most commonly affects the young adults in their 20s, and then again in adults over the age of 55. It's slightly more common in men, but has a strong association with Epstein-Barr virus infections. So a lot of times we'll see the hallmark painless supraclavicular or other lymphadenopathy, cervical region, mediastinal region, and they have the classic B symptoms. The B symptoms are fever, night sweats, unintentional weight loss, infections. Another classic clue is pain in the lymph nodes after alcohol consumption, which is really classic for Hodgkin lymphoma. On labs, you might also see kind of a nonspecific elevated ESR, and treatment really just depends on the staging, but we usually use a combination chemotherapy. And Hodgkin lymphoma is one of the most curable cancers that there is, especially in the early stages, and even advanced cases often achieve long-term remission. As far as non-Hodgkin's lymphoma, it usually refers to a diverse group of lymphoid malignancies from B cells, T cells, or NK cells. It has a way worse prognosis than the Hodgkin lymphoma. There are a few subtypes, which we won't go into. The only one that I'll mention is the most common subtype is usually diffuse large B cell lymphoma. Risk factors for this really include HIV or immunocompromised state, like organ transplant, HIV, and they usually present again with painless lymphadenopathy and the constitutional B symptoms. As far as treatment or diagnosis, we're going to do an excisional biopsy. Then we're going to try to treat, although the indolent forms we might observe until they become symptomatic, then we might use the rituximab. Aggressive forms, we're going to use the R-CHOP chemotherapy. Prognosis is really variable it really just depends on the case, but it has a worse off prognosis than Hodgkin lymphoma. All right, next up is multiple myeloma, and we are really nearing the end. This is really close to the end, so just bear with me here. So multiple myeloma is a malignancy of plasma cells. These are antibody-producing B cells. They become cancerous and basically over-proliferative in the bone marrow. And these plasma cells produce excessive amounts of a single type of immunoglobulin, which is known as monoclonal M proteins. And it's most common in older adults. They often present with back pain. And we want to think about the CRAB mnemonic, CRABB, where C stands for calcium elevation, R stands for renal insufficiency, A for anemia, B bone lesions, and B back pain. And the bone lesions will usually be these punched out lytic lesions. On lab work, you're going to see a normocytic anemia, but you're going to see the classic rouleau formation. And I kind of think of like these lytic lesions, as you get them punched out, they kind of formed coins that stack on one another. You might also see hypercalcemia, elevated creatinine, elevated ESR, and you might see in the urine the Bence-Jones protein. Okay, let's see. As far as clinically speaking, we already talked about bone pain being the most common. Treatment's really going to include immunomodulators, and That's really how we're going to treat that. And then as far as prognosis, multiple myeloma is really incurable, but highly treatable. And so many patients achieve long-term remission on these. So last but not least, we have myelodysplastic syndrome. So this, also known as MDS, is a clonal disorder of the bone marrow stem cells. It basically leads to ineffective blood cell production and cytopenias. It's kind of a pre-leukemic condition because it can advance onto AML, and it usually affects older adults. Symptoms include fatigue, pallor, anemia, easy infections or bruising. It's kind of symptoms of cytopenia across the board. And you'll often see again that macrocytic anemia. Management really just depends on the severity or risk stratification and prognosis. It has a variable course. Some remain stable and others progress to AML. So a pro-PA tip, if you see an older adult with unexplained pancytopenia and hypercellular marrow, you want to think myelodysplastic syndrome. All right, and that really just brings us to the end of our high-yield hematology review. We've covered a lot of ground, so we covered everything from coagulation to bleeding disorders, anemias, hemoglobinopathies, malignancies. I mean, we covered all of it. And if you've made it this far, give yourself some credit. This was pretty long. And I think hematology can feel really dense because it's stuff we can't always see, feel, touch, kind of like derm or some other more tactile modules. A couple things to remember before we go. We need to organize and categorize patterns. So if we start thinking microcytic versus normocytic versus macrocytic, this helps us approach it. And then intrinsic versus extrinsic. And then really when you're in doubt on the PANCE or PANRE, you want to anchor your thinking around some of the more common phrases or buzzwords. I know we're trying to stay away from buzzwords, but you can't always stay away from those classic smear findings like Bence-Jones proteins or rouleau formations or Reed-Sternberg cells. That they're going to help lead you to the correct diagnosis, as well as things like R-rods for AML or smudge cells for CLL or Bence-Jones proteins for multiple myeloma. So really, you just got to try to link those key findings to the diseases that they're associated with. So I want to thank you for hanging out with me. I hope this was helpful as a high-yield review. Hematology, definitely not one of my favorites, but nevertheless, we still have to know it. If you like it, be sure to comment or give a thumbs up below and let me know what other reviews you're looking forward to seeing from us. And again, thanks, and I'll catch you in the next episode.